We're going to be talking about coronary artery disease and angina. Two of them go together. Coronary artery disease causes angina, usually. We will talk a little bit about angina that isn't caused by coronary artery disease, but most of the time it is caused by coronary artery disease. And I got a picture of the heart over here. You can see the aorta, and you got the pulmonary artery coming out here, and coronary vessels. Right, so the coronary circulation comes right out of the base there of the aorta, and it comes out and feeds the entire heart muscle. So whenever you're talking about coronary something, we're talking about the coronary circulation, which is the cardiac circulation, right? It's the coronary vessels are the ones that feed the myocardium. So the vessels come down here and they feed the heart, and they lay on the outside of the heart, the superficial area of the heart, and then they kind of like finger down into the myocardium. And what angina is usually caused, you get a narrowing in one of these vessels. And the amount of angina, the extent of a heart attack, if you end up getting to a heart attack, would be how much muscle is affected. Depends on where the clot is. For instance, if you have a clot way up here, it will affect everything down below there, right? Because you're not getting blood to any of those areas. If you have a clot way down in here, it won't affect as big of an area, right? Or if it's way out in the edge of one of these. Okay, so now we're going to talk a little bit about the process of how this develops, how you end up with these narrowing vessels or clots in the vessels. Okay, so I've got drawn here a coronary vessel. These cells here are the endothelial cells, right? So the endothelium, the inner lining of the vessels. And what happens is, in coronary artery diseases, what happens is some of the cells in the inner lining there get damaged. Takes some kind of irritant, something that's hard on the cells, in order to do that. Cigarette toxins. Right, they can damage the endothelial cells. Low density lipoproteins can, and just high blood pressure. So you get, let's say you got a cigarette toxin in here, right? Right, so it's floating around in there. You might have it might have some high cholesterols, right? So I always like to draw them like a star. It's got all those points, and they're kind of hard on the edges if they come down and poke on those on the endothelial cells. And then the blood pressure, it's just plain old straightforward pressure exerted on the walls of the endothelium, and it can damage the cells. So all these things here can damage the cells. Once you get some damage to the cells, right, so we've got some boom, 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 we've got some damage done to the endothelial cells right there from some kind of irritant. And by the way, those aren't the only three irritants, they're just like the top three, the easy ones to come up with. And so now you get kind of an inflamed in that area. So you get a little bit of inflammation, right? Get some space now, a little more permeable here. And what the odd thing is in these cardiac vessels, cholesterol just loves to come down in here and lay underneath these endothelial cells down in the intima. That's that second layer. So they kind of lay in there. They get in there, and you get a buildup of fat in there. And at the same time, when you get something in there like that, and you've already got this inflammation, you're calling white blood cells to the area, right? So white blood cells are all coming over to the area, and they're going to get in there and try to eat up that cholesterol in there. So this isn't normal. We need to get rid of this. So they come down in here, right? And they're in here trying to eat all this up. So see, they got those mouths on them, right? So they come in there and they're trying to eat these up, these white blood cells. So now we've got this streak here of cholesterol. So it's a fatty streak, and you're getting some white blood cells in there trying to eat that fat up. And that's that area. Well, the first area there, when you get the damage, that's here. The second area, and if you look in your book, on page, if you got Lewis 10, it's on page 703, and it shows these different stages. So you got the damage stage, now we got the fatty streak stage, right? And that's the fatty streak stage of coronary artery disease. Now what happens is these white blood cells, these macrophages, they come in there and they just engorge themselves with this cholesterol. And they get really big and fat and die. And so now you got all these big white cells in there. Somebody that named these cells must have looked under a microscope and thought, hey, these guys, it looks like foam in there, because they're called foam cells. So now you got foam cells, right? And they must look like foam. Never seen them, only read about them. So you get these here, and you're getting this here, and you're getting this, and it's kind of bulging out into the right. You got all that cholesterol, occasional foam cells. So now you've got it building out a little bit into the lumen of the vessel. And what happens is now, at this point here, the smooth muscle layer here begins to try to grow around this. Whenever we have inflammation and whenever we get that, and it's a process that's going on, our system wants to encapsulate it. It tries to encapsulate this. So these smooth muscle cells here kind of migrate up through here, and they grow, they kind of try to grow over the top of it. In the meantime, this guy here is just growing bigger, right? I'm going to go ahead and draw it really kind of big here. Trying to make a point here what it would be like. And so you end up with the endothelial cells covering it, along with some smooth muscle cells in there. These cells here, these foam cells, they crystallize too. When they're full of the cholesterol and they die, they end up crystallizing. And these here blue ones here that I drew in here are calcium cells, right? So calcium gets hard too. So this is a pretty hard fibrous cap now that they call that fibrous plaque, right? So now this here stage is called plaque, right? And it's brittle. So now if you look at this, let's say we were to do a cross section, boom, cut it right down the middle and look down that lumen to see what it looks like. I will kind of draw it over here. There, that's a little better. Now you can see it. It's taking up half of your lumen, right? So you're not going to get as much blood supply through there. So if you look back here at the heart, you got an area that's narrowed like that. You're not going to get as much blood. Now you're getting blood through there. You're getting blood through there, but you're not getting as much blood, right? Because it's narrowed. It's narrowed. Right up here we're showing the lumen, right? And you only got half of the lumen open for blood to pass through. So what's going to happen, right? You've got this narrowed lumen here. Everything downstream is not going to be getting the amount of blood that it needs. Well, what happens here, this is when a person has stable angina. Right, so at this point they've got stable angina. And what that is you've got the narrowed lumen, you got compromised blood distal to the spot there with the plaque in it, and at rest you're okay. But when you get up and start moving around, like a guy goes to cut his grass, every time he goes to cut his grass, he ends up with chest pain. So when the heart is having to work harder because the person is doing something, some vigorous activity, well, they can't get enough blood through that narrowed spot. At rest, okay, doing something, they get chest pain, and you'll hear that. You'll hear, every time I cut the grass, I get chest pain. You know, I have to sit down, it goes away. That's stable angina. A guy that I took care of one time said that he had chest pain, and I said, well, have you had this before? And he says, I actually get it every Thursday. I have to climb this ladder, this really tall building, and he has to go up there and lubricate something at work. And in doing that, and if you saw this building, it's huge. I mean, it would be quite a task to climb up this ladder. He says, I always would get a chest pain, and I started taking my lunch up there. I would do the lubrication job that I had to do, and then I would sit down and take my lunch, eat my lunch, and rest a little bit before I went down, because I'd always have this chest pain from climbing that ladder. But anyway, he ended up with, he had stable angina. So what do you do for stable angina? Well, these are the people that maybe can take their sublingual nitroglycerin before they do the activity. I would be a little bit leery about telling that guy who's going to be climbing the ladder to take sublingual nitro, because it can make you a little bit lightheaded with the drop in blood pressure that you get from that. But if it's a guy who's out cutting his grass or something, tell him to sit down, take that nitroglycerin like 15 minutes before he's going to go and do his job there, and then rest, and then go ahead and do it. Break the job up into a couple smaller jobs so he doesn't do it all at once, right? You can give him some advice like that, or hire a kid to do it, At this point, it's stable angina. Now let's talk about unstable angina. Unstable angina is a very serious condition because you're losing circulation completely to the area distal to the area where there's a clot. And it can lead to an MI if it doesn't resolve itself. Now, stable angina, you got a narrowed vessel. Unstable angina, you've got something that is periodically cutting off circulation down there. And if it ends up not being a periodic thing, it's going to end up causing a myocardial infarction. The problem is, this is brittle. Brittle, and you end up with a complicated lesion. You get cracks in this. Right? Let's say you get a crack in there. Well, the endothelium is all antithrombogenic, right? So with the endothelium, it's antithrombogenic because it releases things that prevent thrombosis, prevent clotting. So you've got like a heparin-like molecule and some different things in there that are released by those endothelial cells, and they will prevent clotting on the endothelium. But now, below this fibrous cap, you have thrombogenic surfaces. That means that clots will form when they come in contact with it. I mean, blood will clot on almost anything, right? So you get cracks in here. Now you can develop, well, I got a pretty good sized crack right there, right? Now blood comes along here, the platelets come along, and they'll stick to that. Boom, 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 boom. And now you got this big old clot forming on here. And it can clot off all of the circulation. So now that you get this big clot forming on top of there, it's cutting off circulation down past there, right? So now they'll have unstable angina. Now, if that clot clears, if it didn't take very long, if it wasn't there for a real long time and it didn't get fibrin set in there, it might clear itself out. So another thing that can happen here, you've got these cracks in this system. Some of this cap here can kind of come loose, right? So this here starts flapping up here. Maybe it kind of breaks off here, and this chunk here will flip up here, right? And then it kind of flips back down and then flips up, right? So this thing is unstable, so it might clot it off a little bit, and then it doesn't, and then it does, right? And that there would be an unstable angina too, because it's not just something that's happening because of the narrow vessel. It's something's happening periodically, cutting off the circulation downstream from the area that's narrowed there. When they have stable angina, nitro helps really well. How come? Well, if you think about it, let's go back and look at stable angina again. This is all open here, right? And you've got half of that cut off. They're really active. What happens when you take a nitroglycerin? It vasodilates, right? Put it under your tongue, it gets absorbed right into the arterial system, straight down into the heart muscle, and it causes all of those coronary vessels to vasodilate. It causes your systemic vessels to vasodilate too. That's why your blood pressure drops, right? But the coronary vessels cause them to vasodilate, and you can get more blood down past there. Works really, really well, amazingly well. When you get unstable angina, it is not relieved with nitroglycerin, right? Another thing about unstable angina, they got it even when they rest, right? Stable angina, they rest, it goes away. Unstable angina, it doesn't, because you're clotted off. It doesn't matter if you're resting or not, you're not getting any blood down there. In stable angina, you're getting some blood, just not enough for activity. Unstable angina, no blood. So that's two huge differences between the two. If you look down here, it can end up leading to an MI. And what's an MI? A myocardial infarction, right? Heart attack, layperson calls them. So an MI, myocardial infarction, what that means is this has been clotted off to enough time that a portion of the cardiac muscle down there has died, right? It's been clotted off to the point where some of that cardiac muscle has actually died, and that's when they had a heart attack. The ischemic pain is the angina, right? They're getting ischemia. Ischemia means a lack of oxygen to the area. So that's what we got going on with these couple of things.